Hello and welcome. Today we're covering one of the most paradoxical and dangerous adverse drug reactions in medicine, heparin-induced thrombocytopenia, or HIT. This is a condition where heparin, a drug given to prevent blood clots, does the exact opposite and causes catastrophic clotting. Understanding how to recognize and manage HIT is absolutely critical, so let's dive in. So, what exactly is HIT? It's not a simple side effect, it's a powerful and aggressive immune mediated reaction. It's defined by two key features that happen at the same time. First, thrombocytopenia, which is a significant drop in the patient's platelet count. And second, paradoxical thrombosis, meaning the patient develops new or worsening blood clots. This is the most important concept to grasp. Despite the low platelet count, the number one danger in HIT is massive, life threatening clotting, not bleeding. To understand HIT, you have to understand the chain reaction that causes it. First, heparin molecules in the bloodstream bind to a protein found on platelets called platelet factor 4, or PF4. For some reason, in certain patients, the immune system misidentifies this heparin PF4 complex as a foreign invader and creates powerful IgG antibodies to attack it. These antibodies then lock onto the heparin PF4 complexes sitting on the surface of platelets. But here's the crucial part. This binding doesn't destroy the platelets. Instead, it acts like a master switch, causing massive platelet activation. These activated platelets start clumping together, forming dangerous blood clots. At the same time, the spleen recognizes these antibody-coated platelets and begins removing them from circulation, causing the platelet count to plummet. The hallmark sign that should make you immediately think of HIT is a drop in the platelet count by more than 50% from the patient's baseline. The timing is also a major clue, as this drop typically happens about 5 to 10 days after heparin was started. And remember, it's the relative drop that matters, not the absolute number. A patient's platelet count could drop from 400,000 to 180,000. While 1,080,000 is still in the normal range, that is a greater than 50% drop and is extremely concerning for HIT. Let's talk more about the biggest danger, thrombosis. Because the core problem in HIT is widespread platelet activation. The patient enters a hypercoagulable state. This can lead to devastating clots anywhere in the body. This includes venous clots, like a deep vein thrombosis or a pulmonary embolism, as well as arterial clots, which can cause a heart attack, a stroke, or cut off blood flow to a limb. In fact, the risk of developing a major clot in a patient with untreated HIT is over 50%. When we suspect HIT, we don't wait for labs to come back to start acting, but we do use a scoring system to assess the probability. It's called the 4TS score. The 4TS stand for thrombocytopenia. How big was the platelet drop? Timing. When did it happen? Thrombosis. Is there a new clot? And are there other possible causes for the low platelets? A high 4T score gives us a strong clinical suspicion and tells us we need to send off for confirmatory lab tests, like a HIT antibody ELISA. If HIT is suspected, the management protocol calls for immediate and decisive action. The first and most important intervention is to stop all forms of heparin. This includes IV heparin drips, low molecular weight heparin like enoxaparin, heparin flushes for IV lines, and even heparin-coated catheters. All sources must be discontinued. Second, platelet transfusions are strongly contraindicated. This is because giving platelets can be like throwing fuel on a fire, as the new platelets would also become activated by the HIT antibodies, worsening the clotting. Third, a non-heparin anticoagulant is initiated immediately. This is necessary because the patient is at an extreme risk for clotting and requires therapeutic anticoagulation. Common choices include argatroban or bivalirudin. Let's quickly recap the most important points. HIT is an immune reaction. The hallmark is a greater than 50% drop in platelets, usually 5 to 10 days after starting heparin. The primary danger is thrombosis, not bleeding. If HIT is suspected, the standard of care involves stopping all heparin, avoiding platelet transfusions, and starting a non-heparin anticoagulant. And that is your essential guide to heparin-induced thrombocytopenia. Thank you so much for watching. I hope this video clarified this complex but vital topic. If you have any questions, please ask them in the comment section below. If you found this helpful, please hit that like button and subscribe for more critical care and nursing content. And let me know what subject you'd like me to cover next. Stay vigilant and see you in the next video.